there, welcome back to another I Care for Your Brain with me, board-certified neuropsychologist Dr. Karen Sullivan, also the author of the I Care for Your Brain Interactive Stroke Recovery Guide that gives you the 10 rules of rehab that you need to know in order to optimize your recovery. Tonight's brain health lecture topic is hypertension or high blood pressure, and we're going to do a specific focus on what you need to know after a stroke. We are currently in heart attack season. You might not know it, but we certainly are. We have been enjoying all sorts of high fat, high sugar, high alcohol foods and drink, and more people in the US actually die between Christmas Day and January 7th than any other time in the whole year, and this is mostly attributable to vascular events. High blood pressure is the most influential risk factor on who gets a stroke. So I know some of you following me are stroke survivors and stroke thrivers, so this information should be very, very useful to you. Having poorly controlled blood pressure increases your risk of having a stroke by up to 6 times. That is really, really significant. And this is especially the case if you have had a hemorrhagic stroke or a brain bleed. So tonight, what we're going to focus on is what you need to know, what kind of maybe got you into this situation with a stroke to begin with, what was happening during the stroke, and most importantly, what do you need to do now to reduce your risk of having a future additional stroke. About 85% of people who've had a stroke have had high blood pressure, whether that was prior or actually during the event. The risk of having a stroke goes up proportionally, as does the numbers in the blood pressure reading. So on top, we have your systolic, and the bottom number is your diastolic. And it's important to understand what these numbers actually measure and what these numbers actually mean. So your risk of stroke actually goes up as soon as we get above 115 or 120 on the top number and 75 on the bottom number. Now, what we really see, what we really need to pay attention to is the bigger jump that happens once we get above 140 over 90. Okay, so this is considered to be the danger zone. There is a significant impact of age on blood pressure. So once we actually hit 65, the way blood pressure and stroke risk interacts, it increases our risk of having a stroke about 2.5 times more if we're a man and 3 times more if we are a woman. So that top number, that systolic pressure, is actually the maximum pressure that the heart is exerting while beating. And the bottom number, the diastolic pressure, this is the amount of pressure in the arteries between beats. So that's one of the missions of the I Care for Your Brain education program, is I want to demystify some of these terms for you so you are a better consumer in the room when you're talking with your neurologist or your primary care physician. So up until about 2019, most studies were really focused on the top number, okay? So that's that higher systolic pressure when compared with a elevated bottom number. And this was especially thought to be the case once you got over the age of 50, because as we get older, that top number actually steadily gets higher, which is part of why the risk gets so much higher. And the diastolic, the bottom number, actually seems to peak more when we're in our 40s, and then it actually declines once we get into our 60s and beyond. But we do have a very good grasp right now that both numbers are actually important, so don't let anyone fool you into thinking just the top number is important. The most recent blood pressure recommendations from the American Heart Association came out in 2017, so we're actually ready for an update. And what they told us is how widespread hypertension is as a start. So about 47% of Americans meet criteria for having high blood pressure, which they define as anything over 130 over 80, okay? And 74% of the people that should be on meds or should be eating a low salt diet and should be more physically active do not do that, okay? So this is a very significant problem. Once we get over that 65 years old, about 76% of Americans have uncontrolled blood pressure. That's really pretty significant. So it's a problem because of the way it impacts our blood vessels. Our heart being the largest vascular blood factory in the whole body, of course, and it makes the workload of the heart much harder and damages arteries and organs and veins over time. So the smallest blood vessels in the whole body are at greatest risk, right? That makes sense because they're the smallest diameter. And where do you think the smallest blood vessels in the whole body are? Yes, in the brain, but also in the eyes, in the feet, and in the kidneys. And oftentimes that's where you see vascular related issues, including hypertension, actually wind up culminating in their damage. So there's two types of risk factors that can increase your chances of developing high blood pressure. Some you can improve and treat, and some you can't. So there's many more that we consider to be modifiable, meaning you can actually treat them. So there's 9 major modifiable risk factors for hypertension. Would you like to know what they are? I think you would. The first one is poorly controlled diabetes. Okay, so not having it, and not when it's well controlled with medicine or lifestyle diet, but when it's poorly controlled and when your blood glucose levels fluctuate dramatically down and up. The next one is carrying more weight than is healthy for you. Next one is high bad cholesterol, the LDL stuff, or low good cholesterol, HDL. Physical inactivity is our next one. Untreated obstructive sleep apnea, poor diet, and when we're talking about high blood pressure, the poor diet is specifically one that is high in sodium, low in potassium, and too high in alcohol. Those are the 3 factors of an unhealthy diet specifically for high blood pressure. We also know that cigarette smoking is a big risk factor, and this also includes exposure to secondhand smoke. So even if you don't smoke and someone who lives in your home does, that's going to be a problem. The final 2 are chronic kidney disease, and the final one surprised me a little bit. It was history of preeclampsia. So this is a very common hypertensive disorder that happens at end-stage pregnancy and increases your long-term risk of having hypertension by about 4 to 5-fold. So that's pretty significant. The other set of risk factors are those modifiable ones, and with blood pressure, there's really only 2 that you can't change. The first one is simply your age and getting older, and the next one is being born a male. Hypertension is the most powerful driver of what we call cerebrovascular disease, specifically in those small vessels. If you're interested in white matter disease, that was a topic I did back in December because so many people find it as an incidental mention in an MRI report and get very concerned, rightfully scared, because no one has really explained it to them. So if that's something you're interested in, you can go back and see that lecture. Your risk of having a stroke increases by every unit increase over that 140 that we talked about before, that systolic number. So for every unit you get above 140, you are increasing your risk of stroke by about 18 to 20%. And for every unit increase in the bottom number, the diastolic, above 90, this is increasing your risk by about 6%. So the top number is a little bit more influential, but the bottom one also matters. Many of you know that there are 2 types of stroke. We have ischemic stroke, which is about 80% of people, and this is caused by a narrow or clogged blood vessel in the brain that cuts off blood flow to a specific part of the brain and brain cells. Little or no blood flow means little or no oxygen, little or no glucose, little or no micronutrients, and this is how brain cells die, unfortunately, or get damaged. About 20% of strokes are hemorrhagic, and this happens when a blood vessel ruptures. 2 types of high blood pressure are the main causes of this type of stroke. First one is someone has had chronically high blood pressure for decades, long time. The other way is that it gets acutely high in a very short amount of time and that it's very abnormal for the person. This is not a part of their normal health history. What we consider to be very high blood pressure is anything above 180 over 120. This is actually called a hypertensive emergency, and they're common in people who are non-compliant with their medications, meaning you should take high blood pressure medication, but you don't. Very important, almost as important as with a blood thinner, High blood pressure medications are critical that you take them every single day, as if your life literally depended on it. For a while, I was working in an inpatient stroke unit, and we would see many people on Monday mornings who forgot to take their blood pressure medications with them on a weekend vacation, a weekend away. So that really drove home the point for me of just how important it is. People who have chronically not so good blood pressure can actually tolerate peaks in blood pressure a lot more than people who don't have it. So the point here is the more unusual it is for you to have a big peak of blood pressure, the more you need to do something urgently about it. If you have recurrent hypertensive emergencies, the 1-year death rate associated with this is about 80%, and the mean survival rate is under a year. So your blood pressure cannot go sky high repeatedly over time. Your body can just not handle it. You will not live very long with extremely high blood pressure. As I said before, the blood pressure really strains blood vessels, and over time this degrades the elastin, that is the inside part, the inside fibers of blood vessels. Really think of it like kind of the vascular wall, the vascular lining, and it's meant to be smooth and elastic and flexible and able to contract or expand depending on the needs of the person's body and brain. And that's what changes when you have bad blood pressure, high blood pressure over time, is that the blood vessels actually become very stiff and inflexible and are unable to maintain their smooth structure. So what happens is they develop little micro tears on the inside. So imagine this is just like a balloon that can stretch and stretch and stretch, but ultimately has a breaking point. And when it breaks, it kind of has these ragged pieces to it. Exact same thing happens within our blood vessels. And these micro tears do two really bad things. The first one is that they create inflammation, which then further narrows the blood vessel, preventing the blood flow from getting in and nourishing brain cells. In those little tears, we also see that they're the perfect little house for blood clots, pieces of cholesterol, that can set up shop there temporarily, but during another episode of extreme hypertension, they can ultimately break off and float downstream, causing a stroke. This is not what we want. In ischemic stroke, we also see that at the moment of the blockage, people's blood pressure can go really high. And this actually makes a lot of sense because there's a blockage, the body is very smart, and it is basically trying to push the clot, push the group of fat, whatever the embolism, whatever is blocking the blood vessel, to the side to resume normal blood flow. So it's very, very common that as you go to the emergency room for an ischemic stroke, when they take your blood pressure, it's going to be extremely high. And what we actually see in people who have embolic strokes, which is an embolism that has traveled from somewhere else in the body that then gets caught in a blood vessel in the brain, is that you can have what we call a stuttering course, which is where symptoms within an hour, 2 hours time come and go. And that's because the blood pressure raises and it moves the embolism over to the side of the blood vessel and blood flow can resume. So it can actually be very adaptive during a stroke to have a temporary increase in blood pressure. So the opposite is kind of true in the hemorrhagic strokes if you are someone who is in that category. So the concern that we have, of course, is that the hypertension, or any type of other reason that people get into hemorrhagic stroke is going to be worse when there is more blood that is in the brain that shouldn't be there. Blood is very what we call caustic to the brain. Brain does not like it. It's very common to have seizures after hemorrhagic strokes because of this reason. But we also see that people can often have significant deterioration right after a hemorrhagic stroke because of intracranial pressure. There's just cells, blood cells that are there that shouldn't, that take up precious real estate, and the brain can only fold in and of itself so many times before there's just literally no more room. And if someone doesn't get relief of the pressure through a craniotomy in a very narrow window, unfortunately the brain tends to herniate backwards, and this is where we see people can have brainstem death and then death. Part of your care that needs to be very personal after a stroke, like so many other things, is blood pressure. So I cannot give you specifics, and this is not your personal time with your doctor. I am here to give you some generalizations from the research that you can take back to your doctor to be a better advocate for yourself. So what we do know is that once you've had a stroke, unfortunately, you are at increased risk for having another one. Most people, if they're going to have a second or a third stroke, it happens between 12 to 18 months after they've had their first stroke. And this is very much driven by blood pressure, which is why it motivated me to want to do this lecture with you, so you have the very best information. So one study showed that uncontrolled hypertension 3 months after someone had a hemorrhagic stroke was the best predictor of poor long-term blood pressure control, as well as dying or having another stroke. So after you have a hemorrhagic stroke, managing this blood pressure is the most important job that I think you have in terms of your physical health. You have a lot of other jobs for your emotional health and managing the stress and the trauma of this acute medical issue, but what I really want you to know is how important it is to maintain stable blood pressure. So one of the most important messages you're going to hear from me today is, how can you monitor this? Because it turns out the one shot that you get in the doctor's office is really not a very sensitive indicator at all, and you really need to take this part of your health into your own hands, okay? So what we know is that if you've had a stroke of any kind, the goal is that you want your blood pressure to be as steady between 130 and 140 as humanly possible at all times. You might think lower blood pressure is actually better, but there's no evidence that once you go under 120, you actually get any clinical benefit, and in fact, you might also get kidney damage. So it's a very, very fine line between what is the optimal range for blood pressure. It's a very delicate process. Blood pressure is something that has to be raised in a very, very slow way. It's not something the brain can handle having big, if you tend to be chronically high, we don't want someone to, in a very short amount of time, come back down to normal, because that can actually cause damage as well. So what we do know is when you have uncontrolled high blood pressure, if you're at risk for having another stroke, at higher risk, but when you have that second stroke with bad blood pressure, you're also at higher risk for having a larger stroke and having a worse outcome. Okay, so this is, I hope, very motivating information for you. The more strokes you have, the more deficits you're going to have, the lower your chances of a great recovery are going to be, the lower your chances of survival are going to be. And you really need to focus on what we call secondary prevention. Okay, so secondary prevention in stroke, again, very, very personal. It matters. So many different details matter. Was your blood pressure an acute problem? Did it seem to come out of nowhere? Was it the end? Was the stroke there because you actually had it for 10, 15, 20 years and didn't take it serious enough, that your diet was poor, you didn't do enough physical activity? So it's very much, you need to go into your doctor and ask them why they think your blood pressure was poorly controlled and what are their personal recommendations to help you get back on track. So remember before I said there is one thing I need you to do to take care of this part of your health better, and that is making sure that you are monitoring your blood pressure in the best possible way. So if you are able to get the blood pressure down and manage it, this can reduce your risk of having another stroke by 30%. Now, if you get it down to 30%, that's only 13% more than somebody who has never had a stroke, okay? So that is pretty significant. So the average person walking around has about a 4% risk of having a stroke. If your blood pressure is well controlled, you're at about a 13% risk. And if it's poorly controlled, you're at about a 30% risk. So look at how much power and control you have right there just by managing this one aspect of your health. Now, if you have a stroke and you survive it, you live a month after, your likelihood of dying in the first year is about 10%. Okay, so we have about 80 to 90% of survival from strokes. This has not been the case at any time throughout history. And part of this is our very successful public health efforts in getting out the message that time is brain, and the advent of the clot busting drugs, the TPAs of the world. So when I went and looked at the literature, I really wanted to understand, how could I guide people with blood pressure? The best data I found was a meta-analysis that revealed this 30% reduction. And so I don't want you to be unrealistic and think that you can reduce your risk completely, but I also want you to know that you actually have a lot of power here to modify and reduce this blood pressure. So remember, the best literature tells you after a stroke or after a TIA, around 130 is really, really optimal. So how do we judge who has high blood pressure or how blood pressure medication regimens are working? We go to the doctor and they take our blood pressure. Well, turns out that's actually very insensitive, and many progressive cardiologists, progressive neurologists are really transitioning towards advocating for 24-hour ambulatory blood pressure monitoring. So this is very, very kind of cutting edge, but my thought is if it's in the literature, just because it hasn't made it to Medicare or Blue Cross Blue Shield yet, doesn't mean you shouldn't have access to it. So I first want you to understand. So the most important thing the research tells us is that you need to capture the changes that happen in blood pressure over a 24-hour cycle. This is very, very clear. So a 24-hour capture gives you daytime and nighttime blood pressure profiles, the difference between day and night, which turns out is very important, the increase when you get up and get moving in the morning, and what the variability is over a 24-hour period. These numbers are like gold for the doctor to figure out exactly how to optimize your blood pressure. So your job is to get your hands on a monitor, and either that data can be transmitted to your doctor electronically, we'll talk about that in a minute, or you're just gonna write down the numbers and bring them in an old-fashioned diary, okay? In the next 5 years, I predict that when people leave the hospital with a stroke, they will also be leaving with a home-based blood pressure monitor. That's how helpful they are. So the first thing you can do is ask your doctor if they have them. Many doctors are buying one or two for the office so they can have a loan program because they know how critical important it is. You can get one for about $120 on Amazon. There are some significant barriers, though, in the widespread use of home-based blood pressure monitoring. The first one is, of course, what we need and what we deserve is universal insurance coverage. Right now, you can't get one unless you have end-stage kidney disease, so it doesn't matter if you've had a stroke, they're not going to pay. We also have to make sure we have more people with access to high-speed internet for transmitting the data back to the physician. And the third one is very practical. We actually do a very poor job of making sure that blood pressure cuffs fit people. So the National Health and Nutrition Examination Survey was from 2007 to 2010, showed that 52% of men and 38% of women with hypertension, so they've been diagnosed, require a size large or greater of the blood pressure cuff, okay? But doctors' offices don't have them, and in fact, they really are not widely available at all. They actually cost about $100 more. A universal blood pressure cuff has actually been developed that would fit most arms, but it's only been patented for use in those kiosks that you see in drugstores and not actually available for personal home use. So you may order one from Amazon, and if you don't order an extra large cuff, if you are a bigger person, it's actually not going to be giving you accurate readings. So that's a very important part that you need to take into account. Treatment for high blood pressure comes in many different types of medicines. There's actually 11 different classes of medications. That's kind of why it makes it hard for me to give you any more specific direction in terms of that. Also, I'm a neuropsychologist, not a physician. You need to speak with your physician about that. But I do want to add in one little caveat with medications because there is some concern about treatment that you might not know. Hypertension in older adults, as we've established, is very negative for health outcomes, including stroke, right? Heart failure, there's many different things. And blood pressure medication really does work in addition to lifestyle changes that we're going to talk about. But There is a time period between the first 7 and 45 days after someone starts to take high blood pressure medication that there is a risk for significant side effects. And basically this is blood pressure going too low, people having falls, there can be electrolyte imbalances. So specifically the risk of falls and fracture was found to be increased in those first month and a half. 69% of falls in this period were attributable to medication, and about 43% increased risk for hip fracture. So that's no joke. So watch yourself or somebody that you love very closely after it is that they start taking blood pressure medication. After you've had a stroke, I think many of you are kind of shocked into a state of motivation to want to focus on lifestyle and be healthier, whatever that means for you. Health for your vascular system should really be at the very top of that list. I hope I have convinced you today that blood pressure is the most important factor, but we also know if you have been diagnosed with cholesterol, diabetes, or sleep apnea, these are also incredibly influential disorders on your blood vessel health. So please, if you have any of those, talk with your doctor about how you can be more proactive. The American Heart Association talks about, in addition to managing those symptoms, that there are something they call Life Simple 7 that I wanted to share with you. These are more things that you have more control over in terms of your lifestyle. Okay, so the first one is don't smoke. Don't be around someone who smokes. Make sure you're focusing on a diet that is low in salt. Get enough physical activity. Be a healthy body weight. Make sure your cholesterol numbers are optimized, which also includes higher HDL, the good stuff. Make sure that your blood glucose levels are as stable as possible, and of course that your blood pressure is stable. If you like this type of in-depth education and empowerment, I think you would enjoy the I Care for Your Brain Interactive Stroke Recovery Guide, which is available at www.icfyb.com/guide. Those are the initials for icareforyourbrain.com. Please subscribe to our YouTube channel. Let us know what you think in the comments. The way this keeps going is interactive learning. You learn from me and I learn from you. So please share what thoughts, what experiences you've had on this topic as well. Thanks so much, and I'll see you next time. Bye.